And good afternoon, everyone, and welcome to the next iteration of Spry webinar. Today, we are honored to have Dr. Katie Albright as our special guest. And the topic of discussion will be the future of access, how physical therapists can fill a gap in musculoskeletal care provision and become gatekeepers of musculoskeletal care in the United States. So at first, Katie, thank you for being here, and let me introduce you. Dr. Katie Albright is a physical therapist and an educator who has spent the majority of her clinical career in a multidisciplinary primary care setting. She started her career as an active duty Army physical therapist, where she worked in soldier-centered medical home, co-located with primary care physicians, psychologists, and other valued support personnel. Since then, she has worked in the multidisciplinary care setting and academic health systems in private practices. Dr. Bright founded Redefined Health Education with the mission of getting physical therapists into primary care through education, monitoring, and consulting. She served as the education chair of APTA Federal Primary Care Special Interest Group from 2022 to 2025, where she launched Primary Care PT Summit and Think Tank, and led work groups of consensus definition primary care PT. As of 2025, she is still an active member of Special Interest Group. Dr. Bright is the host of Primary Care PT podcast, teaches continuing education courses related to primary care PT through Redefined Healthcare. So without anything else, Katie, thank you for being here and welcome.
For having me. It's a pleasure.
It is really a pleasure. And through all of the conversations we've had, I think I could not be more excited about our conversation today. So first, we're going to look into some of the topics we're going to cover. And obviously, such a loaded topic, and there's just so much to cover, and we have so little time. So just one or two housekeeping rules. The first one is all of the slides in the future will have a QR code. That QR code will have a article or a publication that will help people who are attending the webinars reference and validate some of the assumptions. The second part is we're going to have a $25 gift card for individuals who complete our surveys and also just who stick around for our webinar. So with that, Katie, I have my first question for you, and that is, can you define what is the role of a physical therapist in a primary care setting?
Yeah, absolutely. And I have a little bit of support with this one because we actually earlier this year just put a consensus definition together for primary care physical therapy because for so many years, everybody was really referring to primary care PT in different ways. Oh, it means direct access. Oh, it means medical screening. Oh, it means prevention. And oh, it means rural health. Or, they were describing the setting, they were describing the competency, they were describing the access, but they weren't describing the entire thing. So we actually do have a consensus definition. And would you like me to read it out, or do you want me to just kind of give the bullet points?
I think both will be wonderful. I think it's good for everyone to hear the consensus as well as the bullet points.
Okay, amazing. So before I read out the whole definition, I'm going to tell you a little bit about the way that it was constructed in a nutshell. So essentially what we did was we put out an initial starting point, and the initial starting point paper was talking about the settings, it was talking about the populations, it was talking about the goals, et cetera, et cetera. This went through several rounds of public comment, followed by several rounds of revision, and then it came to a final vote at CSM earlier this year. And that final vote was either, we drafted a final consensus, we put all of our methods together, and then we had attendees at a public meeting at CSM. Everybody was welcome to attend. It wasn't restricted by membership or anything like that. And we had a unanimous decision to accept the consensus definition. And the way that we drafted this definition was very similar. We wanted it to be in alignment with the way that other professions were defining their role in physical therapy. So, for example, the American Academy of Family Physicians has its own definition of primary care. The primary care behavioral health providers, so primary care psychology, they have their own definition. Same thing with clinical pharmacy, same thing with dietitians. So we wanted to make sure we were hitting all of the major points of like, what is primary care? And ultimately what that came down to is, and I can share a couple of slides as resources after, but this came down to the the attributes of primary care being first contact, or meaning you're part of a team. You don't necessarily have to be the exclusive provider, but you're a part of a team that is addressing the patient's needs as a first point of contact. It has to be integrated, accessible, ongoing, meaning there's not a hard beginning and end date like much of traditional rehab is. Ongoing, comprehensive, meaning broad spectrum. We're covering all bases of health here, not just one isolated practice area, such as orthopedics. Coordinated, person-focused, and community-aligned. And when we pulled out all of those key terms from different professions, we were able to establish our own definition, which, drum roll. So primary care physical therapy is a professional practice area in which physical therapists provide first contact and ongoing broad spectrum preventive and reactive health management services as an integral member of the primary healthcare team. Physical therapist's primary area of expertise is to address pain, disability, function, health, and wellness in order to optimize participation in life activities. And this last sentence is my favorite. The care is person-centered, team-based, and community-aligned with the goal of achieving improved health with higher quality care at lower costs. And that's that.
I think that's right on. And I think that serves the hierarchy of needs where it's person-centered, but it's team-aligned. I think with that in mind, what do you think is the most functional attribute of physical therapy as a profession that positions us as the best tool, the best option for this type of care compared to some of the other professions that are also trying to serve musculoskeletal needs?
Well, in the primary care space specifically, there are so many different health needs that present to primary care that even in our consensus definition paper, we specifically pulled resources that identified that it's no longer just one profession that can tackle or handle all of it. It's different now, and needs are much more complex. And we've recognized as a scientific and a medical community that all of these things, it's very important for it to all come together. We can no longer be in silos and deliver quality care. And so physical therapists in primary care, there is a significant gap in addressing neuromusculoskeletal conditions within the primary care space. And this is no fault to physicians. It is just that you can't address everybody's health needs. You cannot you can't cover and be an expert in everything. When we know musculoskeletal health needs and musculoskeletal risk factors, the physicians are looking at cardiovascular risk factors. They're looking at mental health factors. They're looking at all of these different items. And musculoskeletal is kind of an area where you need a professional to kind of assist in that direction. And so what better professional to help with stratifying, identifying risk, and then putting interventions or strategies into place to mitigate that risk than physical therapists.
Yeah, so right on with that too. But there's it's such an interesting caveat, right? Like we're so used, I think, traditionally of being the physician extenders, and so we're so used to having this. I hate to say subservient role, but really a role of we expect a referral to come in, and then we manage this referral, right? So we're being almost instructed what to do, and I know nobody is really following the referral. But that is more of a mentality that the continuum of care that you were just mentioning is probably not always observed because we're used to seeing these episodic cases. So what responsibilities and what skills do we need to learn to be optimally prepared for this new role, new function?
That's a really good question. And a lot of the skills physical therapists already have. It's just a matter of being able to apply the skills in a way that are conducive to the environment and what the patient's needs are. So I'll give an example. A patient in a traditional rehab environment would be expected to receive a referral or receive a patient. You put in, quote, evaluation on your schedule. And then typically what will happen is the patient is, and even the business model will expect a patient to come back in, 2 to 3 days a week for a certain period of time. And then that's followed by sort of a hard discharge. Now, there's two reasons. There's really a primary reason why it is this way. And one is the historical context of our profession was specifically related to rehab needs after surgery, after a major injury or some kind of significant trauma, a hospitalization. But it wasn't necessarily, back in the 50s, 60s, 70s, physical therapists weren't necessarily seeing your everyday neck pain or, that shoulder pain that just isn't going away. Or, oh, by the way, I started developing this dizziness and it's making me kind of stumble on my feet. Physical therapists weren't looked at as the profession to do that. So historical context is number one. Number two is insurance models and the fee-for-service insurance model. The way that it has been set up and the codes, the intervention codes, the CPT codes that we're restricted to, they do not capture the scope that we have right now. And so, unfortunately, what has happened is even though our profession has developed into this doctorate level profession, we have not been given the opportunity to expand our skill set because it's not covered by these CPT codes. And therefore, since most businesses, many are moving away from it, but since most businesses are functioning off of insurance payment, we are still limiting ourselves to the episode of care model where you do the eval, you do the visit, whatever, a hard discharge, and then if you see the patient back, you got to start all over again. That
Really?
concept doesn't meet the goals of PTs being primary care providers at all.
Yeah, for sure. It's just not practical and not functional based on what the current and modern healthcare looks like. So with that, we have our first survey coming up, and we'll leave the screen on for about 30 seconds. And the question is, which aspect of primary care PT policy is the biggest hurdle for us as a community right now, or for physical therapists in the trenches, right? So what do you think is the biggest hurdle for clinicians adapting this role?
Is that the question for the
Yeah,
survey?
it's a question for everyone, but it's a question for us too. So let's discuss this just briefly. Like, what do you think is conceptually it's fine, right? But being in a clinic and actually seeing patients, people understand. I think clinicians understand the theory, but then there's always an excuse like, well, are we really ready? Like, are we really ready to ditch our old model? So what do you think is the biggest barrier for people in the field for actually adopting this?
Yeah, it's definitely culture. No, like bar none, hands down, it is the culture of what we're used to. So if you have a PT that, let's say they've been in practice for 15 years working in outpatient ortho, it they're used to doing things a certain way. And as I just described, they're used to doing things a certain way. And it is very difficult for somebody who's been practicing for that long or even a student that like their only clinical experience is similar to that model. It's very difficult for them to pull out of that model and be able to function in a primary care environment where a lot of the patients that you see, you might only see them one time, or you might see them one time, and then it might just be the most appropriate thing to see them back in a couple of months for more surveillance and monitoring. A lot of patients, if we want to increase our value within the system, we have to understand how to appropriately stratify risk. For example, patient A is somebody who really should get more consistent rehab. They have antalgic gait, they have uncontrolled pain. They need more consistent and more frequent monitoring. Patient B is somebody who has a little bit of low back pain. It started a couple of weeks ago, but they're able to do most of their, functional activities. They just are having pain. They have some limitations with certain items. That might be a patient that you take a more broad approach and you maybe do some interventions the first time that you see them, but you set them up for success on their own. Another thing too is you're asking that patient what their needs are. You're identifying, is this the kind of person? Is this the kind of person who would be highly successful doing a home exercise program? Or in your screening and in your prognostication and your initial assessment of this type of patient, would they need a little bit more hand holding? And so this all goes into your assessment of like the individual that's in front of you, along with what's expected for the natural history for that problem. So you have to kind of take off your rehab hat and put on more of your what's best for this patient at this current time. And if you say every single patient with a musculoskeletal health need coming into primary care needs PT in a traditional sense, you're not increasing value to the system. And, we can talk about the APTA consumer report a bit, but I'll let you go from there.
Yeah, no, I mean, it's exactly the point. I think understanding complexity, right, and understanding how social determinant of health, how contextual factors all impact recovery, and so understanding that in a complex system, you have to connect nodes through better appreciation of this complexity. So, I think with that, I think we've had direct access in the United States in some form for over 20 years. And in 2025, probably every state has some form or function of direct access, with some states being much more liberal with physical therapy access and some states being a little bit more conservative. But pretty much across the country, if you need physical therapy care, you don't need that physician-based triage before you land to physical therapist in physical therapist office. So with decades of direct access, what do you think is the barrier to adoption to this point, and what has been the barrier, and how do we overcome it?
Again, I think there's a, there's two main issues here. The first one, and actually from the APTA consumer report, awareness of direct access amongst consumers. They specifically say it's growing but limited. Only 41% of the general population knows that PTs can treat without a referral. And it rises to 51% amongst people who have been our patients in the past. So this general perception of the general public, that's a problem. And I truly feel that that's a problem that the insurance market has perpetuated for a long time, because even up to now with Medicare, we still require a referral in order for those claims to be paid. So there's a lot of problems with that. It's not for in certain states and in certain jurisdictions, direct access is legal. It is allowable. However, if an insurance company, a major insurance payer for a huge percentage of the population, will not honor it, then that is a stinking problem right there. The other problem is I'm not certain that there are enough PT organizations, PT businesses, health delivery agencies, if you will, are promoting the concept of direct access. I know that there are a lot that are, but I don't think it's mainstream enough. And I'll give you a personal anecdote. I went to physical therapy. I had hip surgery in 2022, and I went to physical therapy, and I overheard, because PT clinics are just giant HIPAA violations. Everybody's out in this open gym talking about their health problems.
Mhm.
And I overheard another patient ask a PT or a tech or whoever she was working with if she could, if she, a friend of hers was having this issue, if she could just come in. And the person replied and said, no, they need a referral. And it's like, well, no, they don't actually. So I do think that it's not only a culture amongst consumers, but it's also a culture amongst PT and PT delivery organizations that, like, even if direct access is allowed, they're just going to have a referral on hand anyway.
I think that there's a concept of path dependence, right? So like, if
Yes.
you're so used to taking a certain route to your work, and even if somebody shows you a faster route, you're still much more likely to go through that traditional longer route because it's just the path you don't versus the path you don't. And I think that it is interesting how like we just choose not to even enhance it or promote it ourselves as an organization or as a industry. So the results of the previous survey, the question again was, which aspect of primary care PT policy is the biggest hurdle for you right now? And the majority of people answered that is billing and CPT codes, which we already know that a fee-for-service model and this antiquated reimbursement model is just not serving everybody the same way. Not that it's the model that needs to be ditched, but definitely not a model that is to be embraced as the only exclusive model. So I think the question here is to differentiate, is there a risk of adopting primary care position and role for these traditional payers? Is there a risk for them to say, well, we're just going to ignore physical therapy altogether or create this prior authorization barrier that's going to prevent people from gaining access to physical therapy if primary care is provided?
I think that there might have been multiple questions in there. So I'm going to
Yeah.
answer the question of, well, first, before I go on, the question of the difference between direct access and primary care PT is primary care PT is a practice area. Direct access just means you can see a patient without a referral. So you can be a pelvic health therapist that sees a patient without a referral. That doesn't necessarily mean that you're practicing in a primary care PT role. That just means that you're seeing a patient without a referral. So direct access is a component of primary care PT, but again, it doesn't need to be. You can work in a co-located primary care clinic with physicians and nurse practitioners and this and that. They can see a patient first and then warm handoff to you in the same space. Does that necessitate or does that equal direct access per se? No, but it certainly is integrated and interprofessional primary care practice. So on that other note, CPT codes and fee-for-service model. Can somebody who's practicing in a fee-for-service environment practice with the primary care mindset and practice with a primary care approach? Absolutely. There's nothing that is holding you back from doing that right now. Nothing. The only thing that might be a barrier or even just more like a nuisance, it's more of a nuisance than anything else, is you have to kind of put what you're doing within the constraints of whatever the insurance is covering, up to a point where the insurance criteria, where the patient moves away from what that insurance criteria is. But then what you need to do, and what we need to do as a profession, is not restrict ourselves and make sure that we are talking to patients about, okay, this is what your insurance will cover, but this is what our model is. And it's not restricted to what the insurance model is. So work within the constraints of what the insurance company criteria is while you need to, if you choose to. And outside of that, and even from the get-go, let the patient know that you have this more longitudinal model that is going to support their care more long-term than the limitations of what the insurance company will. And then there are payment models for that. And you can address the population that you're working with on a case-by-case basis, whether it's fee for service, whether it's a membership type, a subscription type model, whether it's a partnership with a primary care physician. There's a lot of different ways that you can approach that. But I think that in order to just restrict what we do to what the insurance companies tell us that that's what physical therapy is, we need to break free of that model, build it into our culture so that every single patient that we see that comes in the door understands what we're offering.
And so like that's actually a perfect segue then to the next question, which is, what do you think it will take to build this culture? And certainly this will be with a little bit of a caveat of a bias. What kind of a technology and infrastructure does a clinic need to have to be able to capture some of these essentials in this newly expanded role? And more specifically, what type of technology will be necessary to capture patient-reported outcome measures? How can we package this clinical data into this expanded role so that we can better communicate with other health professionals? So what do you see as an optimal tech stack, an optimal use of technology in a clinic that will support clinicians to optimize the care delivery?
Okay, there are so many different applications for technology. I will give an initial evaluation application, and then I will give a surveillance and monitoring application. So for the initial evaluation, let's say that the scenario is you're a physical therapist, you're working in a co-located primary care clinic, and let's even scrap that. Let's say you are a physical therapist and you have your own walk-in clinic. So you have like a PT urgent care for neuromusculoskeletal complaints, which is happening. There are clinics that offer this. Your patients that come in, let's say you get 3 patients that arrive at 7:59 a.m. and your clinic opens at 8. All 3 of them come at the exact same time or within a 5-minute window. How are you figuring out which patient goes first? So one of the applications for technology is when you have a patient that is completing an intake questionnaire about what their health history, what the chief complaint history is. I call it the 3 Bs in my course. The background, the behavior, and oh my gosh, I'll come back to
Okay.
that. It's like slipping my mind right at this current moment, and it's something that I came up with myself. But anyway, I'll get back to that. But essentially, what's the ultimate history? Within that history, technology can extract that data and apply certain limits to it such that it can pull out not only lifestyle risk, it can pull out family history risk, it can pull out, different types of risks related to the problem, and it can stratify like, okay, this patient is high risk, they have a high severity of pain and irritability of symptoms, and this looks like a patient that needs more urgent care, versus a patient that is kind of lower on the urgency scale. So you can risk stratify, but you can also identify, what patient needs to go first. This is best done when a patient is inputting their information digitally, and then you also have an opportunity to take their vitals. So this would be done, and this could be done anywhere. You could literally have it set up in a waiting area where you have a tablet, it captures all of your information, and then at the end it says, hey, go over and sit in this chair, stick your arm in an automated blood pressure thing, and then it pulls up. Then all of that information transfers into kind of this like purgatory-esque interface where the PT at that time is able to pull up all of this stuff. The technology has already figured out what the risk level is comparing all of these three patients, and then you as the provider get to say, okay, I'm going to take this person first. This person is not as urgent but is going to take a lot of time, so I'm going to put them at the end, etc., etc. So that's just one example of how you can use technology efficiently to figure out which patient goes first and who needs to go a little bit later. But it also can take all of that data and apply it into your documentation so you don't have to waste time on that later. An example of more of a surveillance and monitoring example would be one of the problems with the traditional insurance model is that we cannot, after we hard discharge a patient, we don't have the opportunity to really engage with them anymore and get paid for it. So in a surveillance and monitoring circumstance, let's say we're working with a patient that has had low back pain. We worked with them for, maybe a 8-week period. They're feeling much better, but we also know that a lot of low back pain within a 1-year time frame recurs. So we need to have a mechanism by which that patient is kind of like boosted and reminded of our presence. And so do we have to do that? Do we have to be the people that are, calling them on the phone and asking them questions and doing all of that? Sure, we can. But if we have a high volume of patients and a lot of stuff going on, we can also set technological triggers to reach out to them to ask certain questions, whether that's a bot, whether that is a tech or some kind of administrative person that can ask the questions we need them to ask. It could also be, hey, how are your exercises going? Are you having trouble? And if they are, then let's bring them back in. Let's keep it going. But there has to be a mechanism by which the patients remain engaged within that first 6 months to a year after, quote, discharge, in order to help them improve. This could also be used to help them improve their lifestyle risks, help them improve their step count every day, or, reduce the amount of sugary foods that they're eating, because we know all of this ties into musculoskeletal risk.
Yeah, for sure, right? And for anybody who is still in a clinic using some of these antiquated legacy EMR systems and operating systems, they don't realize how far technology has gone. And certainly this webinar, right, is being hosted by this more advanced EMR system. The level of customization, the level of individual approach to these systems and how they can help you capture this clinical data, they can help you communicate with your customers and patients, and they can help you extend care and really liberate you from these redundant tests that take a lot of time, but do not really need your primary attention. I think that the whole point of physical therapy as a primary care is you are a clinician, you're an expert in your domain, right? And so this expertise needs to translate. So now we have a next survey question on board. And the survey question is, what is the most pressing need for operational triage in your clinic? And for that, I will ask you a different question that we can discuss while this slide is on, which is, what is the best investment of a clinician in terms of, obviously, besides investing in education, which Redefine Health does such a terrific job doing, but what is the best investment on the clinical side from a clinician to optimize their clinical space to deliver this primary care service?
I think everything comes down to systems, making your systems more efficient and higher value. And so when I think about this, and what I've been working on lately is how do we make our systems work better for us, working smarter, not harder. So historically, PTs have done everything themselves. We do literally everything ourselves. And then, we're asked by our organizations to do even more, make sure you're taking that paper and you're scanning it into the system. So I think that the best investment outside of learning the clinical fundamentals, if you are a clinician, learning the clinical fundamentals is setting up operational systems that can support you. And one of the biggest pushbacks I get with that is like, oh, well, we already have our systems. We don't have time to look into anything else. And my response to that at the end of 2025 going into 2026 is you're going to continue on this downward path where you're not going to be able to dig yourself out of. So taking the time to figure out what your systems should be and what your new processes should be, and then training your staff accordingly is probably the most important thing that you can do. And leveraging technology to do that is it's no longer an option. It's a must.
And certainly knowing and understanding how to optimize this technology, right? I think that it is so important to realize that domain expertise again, but also realize that without proper support systems, and these systems really have complexity too. So just like patients present complexity where there's a social determinant of health and contextual factors and demographic factors influence clinical recovery, inside the clinic, these systems need to be connected also. So your front-facing EMR system, your back-facing billing system, your patient communication system, your digital onboarding system are all part of this complex network of methods that if done well, then patient has a seamless experience and the clinician has a seamless experience. And if not, then you're facing with a lot of complexity. So I want to ask more of a personal question about Redefine Healthcare and your own approach. What have you learned in the last couple of years of having this infrastructure organization, and how have these lessons influenced and impacted you as a professional, but also as an educator and as a someone who has this message that they're trying to penetrate the profession?
Oh man, that's a loaded question. But the one thing that really comes to mind with me is clinicians want this. Most there are certainly some PTs that do not want to practice in this type of environment and landscape. It's not for everyone. It really isn't. And we still need PTs who are doing traditional rehab. We still need PTs who are doing more specialized care in pelvic health or in pediatrics or in um, even in like specialized orthopedics. We certainly need those. But for the PTs that really want to do this, I think the thing that I've learned in the last 5 years is that they are being limited by their systems and their organizations. They're not being limited by law, and they're actually not, in my honest opinion, they're not being limited by the CPT codes that we have available to us. I truly believe that we can do everything that we need to do in a primary care mindset under the CPT codes. However, the insurance model ultimately, like I said before, is limiting our ability to go more longitudinal with patients. So there has to be an endpoint there. But I think that the biggest thing, the biggest barrier has been a lack of willingness by organizations to adopt a new model.
Yeah, and I'm actually going to go in a non-traditional route where I don't, I wait for the end of the webinar to ask questions from the audience. But there's a really good question here that I think feeds directly into your response right now, which is from Project Health, how do we make this a reality and applicable, not only in theoretical goals, or what have you seen from some of the organizations you have worked with and how they were able to successfully apply this primary care function into their org?
Okay, I might need you to just repeat that. I kind of looked at the Q&A, but I didn't know which question you were
Oh,
referencing.
yeah.
I'm sorry. Can you just repeat
Uh,
that?
I think we're discussing a lot of strategy, right? But what have you actually seen in the field? Like, because you work with a lot of practices too, and you to optimize primary care delivery.
Mhm.
So, like, can you give a practical example of a healthcare clinic, of a PT clinic, actually applying this primary care principle successfully? So, what comes to the top of your mind on that?
Okay, all right. So there are about six health systems in the United States. There could be more, and I just don't know about them, but there are six that I know of that have PTs full time embedded in their primary care clinics. And so what happens is, and they're all set up just a little bit differently, but they take a physical therapist out of the rehab department and they position them in primary care. And so, whenever a patient with a musculoskeletal or physical function health need presents to primary care, and maybe it's for a totally unrelated reason, maybe it's for a blood pressure check or for a that ingrown toenail that is really bothering them. And then they say, "Oh, I have this back pain," or "Oh, I have this, I've had this dizziness." Then they bring in the PT and actually, work with them right on the ground. So that is happening in about six or seven different locations. Other locations where this is happening, I know of several private practice owners, and private practice groups, I should say, organizations, which have facilitated direct to employer services, whether that's the let's say the employer has this really big need to cover their dependents, maybe not necessarily their direct employees, but they want family member coverage. The employer, which it might be self-insured, pays pays the physical therapy organization directly with no insurance in the middle, and they want help improving their metric of, okay, we have way too, our cost for low back pain claims in this particular population is way too high. What can you do to help us reduce this cost? And so then the PT comes in and addresses it from a more comprehensive perspective. They look at prevention, they look at risk, they look at long-term management, they look at patient engagement. So it's not just those, the individual comes in and like their glutes are weak or whatever. They're looking at it from a bigger population perspective. So there are direct to employer organizations that are doing that. There are also numerous PTs that just practice with this model altogether. Pediatrics is a really great example of that. Most pediatric physical therapists, they set their plans of care for like a year. So if they're doing it, why can't we apply that to an adult population? I know that we can because they're the same insurances. So I think that a lot of this is just the limitation of the historic model. And oh, if a patient isn't seen in 30 days, then the system is going to automatically discharge them. These are just some of the barriers that we need to remove in order to facilitate our ability to practice as primary care providers.
Yeah, absolutely. And just to review, like the last survey question, which was what is the most pressing need for operational triage in your clinic? The answer that got the most votes was workflow for team-based handoff and referrals, which is exactly what you just said, the ability
Mhm.
to navigate and coordinate. If you are in an outpatient orthopedic clinic, then just coordination between the PT and the PTA and a technician. And if you're in the pediatric clinic, and we have this extensive experience here at Spry working with pediatric clients, and so there, the coordination is the key between the PT, the OT and speech, schools. There's just such a large level of involvement from all of the providers, both inside the clinic providers, but as well as outside the clinic providers. And so a process and a product needs to be supported where this communication and handoffs are well defined, but then the system supports these handoffs. So I think that's exactly what we see in a I guess in a real world scenario, right? So the next question for you then is for PTs who are not necessarily ready yet. What type of education, what type of classes, and obviously this is more of what you are doing right now. Like, what is the structure of your education and your courses, and how does a clinician prepare themselves better to serve this primary care role?
Great question. So the reason I started Redefine Health Education, or I started with this primary care PT education track, is because there is a gap between what is happening in physical therapy right now and what PTs really need to be able to do in a primary care environment. So a lot of my education track so I have a primary care physical therapy clinician certification, and the clinician certification takes you from initial evaluation and decision making through monitoring and surveillance, through prevention, wellness, and what our role is in the greater population health space. And so coming back to initial evaluation and decision making, in a traditional PT, historic context, you would see a patient, you evaluate all of their, if we're talking about an orthopedic patient, you evaluate their range of motion, you evaluate their strength, and you evaluate this and that. And then you set this quote plan of care. And the plan of care is they'll come this many days a week, they'll do this home program, yada, yada, yada. In a primary care environment, you may or may not be sending this patient to PT at all. This patient might not be appropriate for your care at all. They may need additional diagnostics. They may need additional specialist input. They may need the emergency department, or they may need the involvement of a behavioral health provider or a primary care psychologist. So your role in primary care is truly to be able to you're a diagnostic expert in the space of musculoskeletal and, well, in physical function too, because we can't forget that cardiovascular and pulmonary is part of our scope of practice. And if we're calling ourselves primary care providers, we cannot just be managing exclusive orthopedic complaints. That's not what it is. We have a bigger scope than that. So the biggest gaps with this, and the things that my education system or my education curriculum addresses, is how do we go from being the treatment experts, the interventionists? How do we go from doing that to being more of the diagnostic, clinical reasoning, and care navigation experts from the get-go, determining what's the best route for the patient at the best time? And then on the flip side, how do we go from this episodic model, which we're used to, which involves discharge, to looking at populations and individuals more longitudinally, how to conduct surveillance and what's appropriate? So my curriculum addresses all of those factors. It teaches therapists what's important from like a screening, red flags perspective, but also from those more social determinants of health, socioeconomic factors, environmental things, education level things, how to put all of those pieces together to make the best decision for the best patient, which may include PT, it may include OT, it may include some other professional that isn't you, but ultimately you're still in that care management role that I don't love the term gatekeeper, but it's a good example for this context.
Yeah. So,
And so you can find all of that in my primary care clinician certification. And in addition to that, if you are a little rusty with musculoskeletal imaging, we have an entire musculoskeletal imaging certification, because even though it is part of entry-level standards, I find that most PTs are not actually incorporating, looking at, and making decisions related to imaging, that most PTs are not doing that, and they really should be.
Yeah. I mean, it is, right? The more you know and the more data you have accessible to you, the better you are as a clinician. So now it is time for the next survey, and this one is a word cloud. And the words we ask you to populate is, what is the biggest opportunity for PTs to expand access in primary care ecosystem? And the question for you, Katie, is how do we include all of the PTs, all of the providers across the spectrum? There's such a large spectrum between the new grads as well as clinicians that have been practicing for 20 plus years. How do we make sure that this primary care model is inclusive through the entire range of your professional experience and expertise, as well as through your clinical and academic background?
Again, tough question because it's my belief, and my beliefs change often based on new information and new experiences and exposures. But my current belief is that this model of care, which truly is a generalist model, it's not just orthopedics, is that there's a lot of PTs who might not want to function in this role, and that's okay. I've accepted that. I think that deep entry level DPT education is doing a pretty good job of providing broad spectral knowledge, but it will be heavy in MSK. It will be heavy in maybe neurologic, but it will be less so in some of the other spaces where, like cardiovascular and pulmonary. That's one of the that really is the hot ticket item. Heart disease and hypertension and heart health is kind of that's the top key aim for CMS to try to tackle. And physical therapists have a role in that. Exercise helps and is one of the most effective things that we can do for heart health. So I'm detracting from your original question, but steer me from there, Alex.
No, I think there's just I think a lot a very large range in PT preparedness, even that we see in just the daily practice, right? And there's also, I think, a more of a predefined role that PTs are accustomed to, and after a certain period and a threshold, we almost lose sight of this larger system that we can incorporate our skill set to. We're just so used to handling patients ABC without going farther. So I think it's certainly attending courses like yours is an excellent step, but I think it will also be through re-examination of your own personal skill set, whether you have any shortfalls or whether you have any additional needs. And then as a practice owners, as a clinicians, right now, 75% of PT clinics have a vacancy. They're actively looking for full-time PTs. What better way to retain clinicians or get new clinicians to come into your system than to provide education as one of the incentives, and then to make sure your clinic is optimized operationally, that your tech stack in the clinic is optimally serving these clinicians where they have access to functions like digital scribe, and they have access to these advanced technology solutions that help you deliver better quality care. So I think there's a lot of it out there. So I think with that, actually, let's discuss this. So how do we ensure that clinicians in the practice provide concordant care? So like things that like clinical practice guidelines and clinical decision support tools are available to clinicians, and the systems such as this one that are available to clinicians too, to support these advanced technologies. So what do we do there?
Again, I think that anything that is going to make the life and the experience of a clinician more simplified in any capacity is the way to go. So I'll use the example that I did with intake and triage before. If you can have your technology systems extract information from a huge, and I won't say huge, it's not huge, but a pretty decent amount of information that's coming from that intake, and stratify it into something that is simple that the clinician can look at, it's going to save time and it's going to improve the overall outcome of that session. And so ultimately, when we're looking at these areas in order to optimize this, there has to be systems in place to ensure that the clinicians are going to ultimately be successful. You can take courses all day, but one of the problems that I've run into with my courses is I'm teaching these models and I'm teaching these strategies to be more efficient, but the translation to their existing infrastructure hasn't been optimized. And so therefore there's less opportunity for it to ultimately be adopted. So in order to make this move, do you have to change everything in order to truly practice like a primary care PT? No, there's some really simple steps that you can take to to do it on a, maybe a more basic scale that climbs. But if you really want to set it up from the get-go, where the entire culture and the entire infrastructure, the entire organization is supportive of this model, that's where you're going to get the most success.
Yeah, look, that's wonderful. So just to review the word cloud, from again, the question was, what is the biggest opportunity for PTs to expand access in primary care ecosystem? And the two words that are most frequently used are access and opportunity. So I think we, as a clinical community, understand that there is a vast opportunity in a primary care field. And we want access to these newly devised instruments and newly devised technologies. So I think with this, we're going to start to close this webinar and open the floor to the questions from the audience. And one of the questions is, I'll read it from this. While this makes sense from the clinical perspective, how does the patient figure out where they need to go within primary care? How can patient have comfort they are being navigated to the right source within primary care? So how does a patient
Yeah.
know that primary care PT is the right tool for them?
Yeah, really good question. And this is why I'm passionate about PTs adopting this model in any way that they can, but I'm particularly passionate about PTs actually being established members of primary care teams. For this reason, we know from the APTA consumer report that the vast majority of the general population, the biggest percentage of the general population, if they have a problem, they're going to go to their primary care provider first. Even if they know that another provider might be accessible, they're going to want to run it by their doc first. Understandably so. They have a relationship with their doctor. They've had, maybe they've been seeing their doctor for like 20 years. But how does the patient understand this when it's something they've never done before? Well, one of the things that I tell organizations that are looking to implement this model is you have to tell the patients about it. You have to, send out awareness materials. You have to have host an open house event. Hey, we're changing up this model. We have new clinicians on site that want to work with you and that are going to be here for you. This is how you can access them. So, and just sending something out once is not effective enough. It has to be a repeated effort. And if you're working with other professionals in that space, let's say primary care physicians, let's say it's the front desk staff, which are going to play a huge role in this, you have to train them in how to talk about what this new model is supportive of. So when a front desk person is on the phone with a patient trying to schedule something, they know that they can see a PT directly. So it's about changing the perspectives of the people that you work with and influencing the culture there first, but also repeatedly reminding patients that are a part of a practice, this is who we have, this is how our pathways work, and this is what you have access to in our clinic. So yeah, I think that one's actually pretty simple.
Like as all life is, right? So there's another really good question. Are those hospital systems using PT in primary care also using them in emergency department? Also, are they tracking data around the cost effectiveness and outcomes of this model? So that's a really good question. Are we actually tracking the function of this model in terms of healthcare economics?
Yeah, I love that you asked that question. So I'll ask, the first question was, are they also functioning in urgent care and emergency department? And in some of the cases, yes. In some of the cases, no. It depends on the site. So for example, Amplify Health is doing this in Wisconsin. They have PTs in both primary care and urgent care and the emergency department where there are emergency departments. I have another example of a health system where they actually started off with PTs in ortho. So, and it was actually the orthopedic surgeons that reached out to the PTs to come into their department to do these evaluations for, probably non-surgical cases or initial cases that they didn't feel were, slam dunk surgical. And the PTs had a hard time with that, if I'm being completely honest. If you want to learn more about that, the second QR code here is a startup workshop specifically for organizational and business leaders. So all of these business models will be represented in this workshop. It's an awesome opportunity. I would highly recommend it because it will answer a lot of your questions. Um,
Uh,
and the second question was, are they tracking outcomes? And yes. And what's great is I'm actually trying to work with them to get them to publish it. Because guess how many data points the VA has? Like millions. And guess how
mhm.
many publications there are? One, literally one. And so it comes down to like these are clinicians that are clinicians and operators that are typically on the ground doing these things. They're not supported by research infrastructure that will capture all of that and publish it in a peer-reviewed journal. I am working on helping them to facilitate that so that they are in more scientific literature.
And that, I think, is perfect. The segue to the next question, where can we find the imaging certification information, which is right in front of you. There's a QR code, right?
Yep.
So this question, which is I think from Bridge Bhutani, which is excellent in a sense that for episode of care, how do we visualize a progression and regression of normative clinical data? The data sources are different. The clinical guidelines are different. There is a limited literature and correlation of treatment parameters across specialties. So what is a single source of truth in this primary care specialty? And what can clinicians who are looking for the single source of truth, what can they trust besides course material? What can they go for this single source of truth?
There is no single source of truth. We work in a complex environment with people that have complex conditions. And there are patterns and there's certain level of population that's going to fit into those patterns. And then there's a certain part of the population that won't. But the goal of a PT being in primary care is instead of just a physician with just a medical background and a medical lens looking at this patient, if they're able to have a PT come in and look at it with their eyes as well, you can help to reduce the number of errors that come out of that. And so I kind of laughed when you're asking for a single source of truth because there isn't one, but we can use clinical practice guidelines and we can use general frameworks to help guide us. It is never going to be perfect, which is why we need to have a human being with experience in this position to make decisions. And not it's never going to be, perfect. It's never perfect, but I think we have enough information about certain problems like ankle pain, like low back pain. We have enough data out there to steer us down into a reasonable starting point. And that's what my curriculum attempts to guide clinicians in how to function. But again, there's uncertainty in literally everything that we do. And it's getting comfortable with that uncertainty and knowing what you do, what you say, I don't know. I'm going to go find someone that does know, or, I'll get back to you later. But we do know a lot. And so I think that starting from a point of knowing what you do know, but also being comfortable with uncertainty is important.
Yeah, and don't make great be the enemy of the good, right? I think
Right,
it's
exactly.
to close things off, I think it's also really important, again, to have technology that is there to support what we do on a clinical side, because in a well-operating clinic, a technology will support your subjective information intake through that scribe feature. It will support objective measure collection and integration. It will support your clinical decision through clinical decision tools, and only advanced technology systems are able to handle this and integrate into the clinic. So as a last question, with 2 minutes to go, are you optimistic or pessimistic about the future of physical therapy in general in the United States?
I am cautiously optimistic. And the reason that I'm saying that is because we need to act right now if we are going to be impactful and if we are going to save the trajectory of our profession. And I do think that right now there's enough momentum to make that happen. And I think that the people that fail to see it are at risk. So I'm very optimistic. I'm cautiously optimistic though because of a lot of other things.
And I think, Dr. Bright, Katie, you are leading the way for this cautious optimism. I think with your efforts, with everything you have done to this point, and everything that is you're going to do in the future, like having leaders like you is the reason why physical therapy is not going to just survive. It's going to thrive. Where I too am cautiously optimistic. Where when we have leaders like you, our profession will continue to make an impactful difference in the healthcare systems. So thank you
Thank
for
you so
this, and thank
much.
you for your time, for being here. I hope everyone finds a time to look at Redefine Health and find you online. And this has been terrific. So again, thank you very much for this.
I really appreciate it. Thanks for bringing me on.
Thank you, everyone.